So my name is Maddie. I'm the Transplant Fellow at the PA this year. Good afternoon, and thank you very much to the organisers for inviting me to present today. This is a case series of 8 patients, one who's already been discussed who had a micropapillary cancer in association with BK nephropathy at the Queensland Kidney Transplant Service. So going through the next 10 minutes, we'll go through the 8 cases, as well as look at the BK DNA EMEA trend within these patients, as well as some of the current treatment options for BK nephropathy and future management plans. So the first case is that of a 60-year-old gentleman who had polycystic kidney disease and underwent transplantation in 2017. He developed BK positivity at 2 months with a level of 5,700 copies. In response to this, his mycophenolate was reduced and kidney biopsy confirmed SV40 positive staining, the hallmark of BK nephropathy, and without evidence of concurrent rejection at this time. Over the following 5 months, he had persistent BK viremia despite the mycophenolate cessation. We trialled leflunomide for this gentleman as well as IVIG therapy. Eventually, he was diagnosed with antibody-mediated rejection with deteriorating graft function and required plasma exchange, as well as the commencement of everolimus in replacement of mycophenolate. At 7 months post-transplant, the BK became undetectable at this stage, but he had chronic graft rejection at this time and returned to dialysis in 2021. At 6 years post-transplant, this gentleman presented with painless hematuria. He went on to have atypical urine cytologies and a cystoscopy that showed a micropapillary bladder cancer at the ureteric anastomosis. This was treated with a TURP, and he continues to undergo surveillance cystoscopy at this stage. The second case is that of a gentleman who was 64 years old with a history of IgA nephropathy. This was his second kidney transplant conducted in 2009, and he did require thymoglobulin induction due to delayed graft function. BK again was positive at about the 2-month mark and at a level of 4,000 copies at detection. His mycophenolate again was weaned and replaced with leflunomide at this time. A biopsy at 9 months in confirmed he had ongoing BK nephropathy and again without rejection. In this setting, tacrolimus was changed over to sirolimus, and over the following 9 years, his BK levels fluctuated to 50 up to 8,000 copies. In 2018, he had an episode of T-cell mediated rejection, requiring escalation of his immunosuppression again. BK levels remained around 1,000 copies per mil after this time. In 2021, he again had an episode of microscopic hematuria, which was noted on a urine dipstick at clinic, and atypical cytologies were detected. He underwent a CT-IV pyelogram, which showed an abnormal region within the bladder, and again a TURP was done and showed papillary-like cancer along the right side of the bladder wall near the graft site. Histology revealed, again, viral inclusions and SV40 positive staining, and he continues under close follow-up at this stage with no evidence of metastatic disease. The third case has already been discussed. And case number 4, this is the only female patient in our case series. This was a lady who had polycystic kidney disease and underwent transplant in 2012. Due to a number of infective complications over the years, she was changed from mycophenolate to azathioprine in 2018. Her BK had been undetectable throughout the first 6 years post-transplant. In 2019, due to some medication misadventure, she developed chronic rejection and resulted in a return to peritoneal dialysis at this time, but remained on tacrolimus and prednisolone. In 2024, she developed acute obstruction within her graft, and a lobulated mass was noted within the transplanted kidney pelvis. She underwent a transplant nephrectomy in the setting of sepsis, and histology revealed an invasive papillary urothelial tumor, again with SV40 positive staining. BK viremia at the time was 740 copies, but in the 5 years prior to her developing this, we don't have any levels, as she was on dialysis at the time and it wasn't being monitored. For our 5th case, this is a 62-year-old gentleman who had a kidney pancreas transplant in 2003. BK viremia was detectable at levels of over 1,000 copies for 3 years between 2006 to 2009. He had reduction in his immunosuppression and eventually BK became undetectable for many years. He remained on azathioprine, tacrolimus and prednisolone as his immunosuppression. In 2018, this gentleman had a creatinine that rose, and imaging revealed an obstruction within the transplanted kidney, secondary to urothelial carcinoma. Staging on his imaging revealed that there was invasion around the bladder neck, and a radical cystoprostatectomy was done, as well as ileal conduit formation. This revealed that there was high-grade urothelial cancer, again of the micropapillary variant that's been discussed, and SV40 positive staining. Repeat staging, conducted only a few months later, revealed metastasis to the pancreas. He underwent a course of palliative chemotherapy, but subsequently passed away. Case number 6, this one is a bit unusual and quite rare. This was a lung transplant in 2010 for congenital emphysema. This gentleman was maintained on standard immunosuppression for many years. In 2016, he had some lower urinary tract symptoms and underwent cystoscopy. And in early 2018, this showed micropapillary urothelial cancer. Further, TERT was conducted after 3 months for surveillance, and he had ongoing locally invasive disease with no evidence of distant metastasis. He proceeded to a cystoprostatectomy due to the depth of invasion, and a pelvic node dissection as well, which was positive. Within 6 months, he represented with metastasis to bowel, causing obstruction and necessitating hemicolectomy. And histologically, again, this showed a micropapillary neoplastic cell with SV40 positivity. He was transitioned to palliative care at this time. In case number 7, this gentleman was 55 and had a kidney pancreas transplant in 2001. At 4 years post-transplant, he developed BK nephropathy. Immunosuppression was reduced, and his microphenolate was converted to azathioprine. Viremia stabilized anywhere between 500 to 3,000 copies. In 2010, he had painless macroscopic hematuria, and a ureteric stenosis was noted on imaging. Cystoscopy showed a urothelial cancer, and he underwent cystectomy and ileal conduit formation. And again, he had a micropapillary variant with SV40 positivity. Unfortunately, after 6 months, this gentleman represented with a small bowel obstruction, and he had peritoneal metastasis and passed away after 6 months. The final case in our series is that of a 52-year-old gentleman who had a live kidney transplant in 2012. After 4 years, he developed BK nephropathy on screening, and treatment including switching microphenolate to leflunomide. BK levels were reduced down to less than 100 for the following 5 years. In 2001, he underwent a hemicolectomy for diverticulitis, and in order to aid wound healing, leflunomide was swapped back to microphenolate low dose. In 2022, he presented with lower urinary tract symptoms, and a cystoscopy showed that he had evidence of a sessile mass, which was resected, and again showing a urothelial cancer with SV40 positive staining. In September of that year, he had a PET scan with no evidence of metastasis. He underwent radiotherapy in November of 2022, and within 4 months represented with a bowel obstruction and a PET scan showing metastasis to this area, which was biopsy confirmed as micropapillary urothelial cancer. This is a very questionable looking graph, but I guess you can see here that the first 3 cases had incredibly high levels of BK at the onset. For the cases 5, 7, and 8, we don't have necessarily the early BK levels because some of these were done interstate down at Sydney for their pancreas transplants. There does seem to be a trend towards the clinically significant and high viral levels early post-transplant, and this is followed over a period of 12 months of clinically significant and high BK levels. Anything above times 10 to the 3 really is something that we're quite concerned about, and a lot of these patients have levels above this for prolonged periods of time. Another thing to note is that for patient 4, there was no data for 4 years prior to her presenting with a malignancy. And again, for the lung transplant patient, he wasn't regularly being screened for BK virus, as that's not part of our normal protocols and quite a rare occurrence. Out of interest, there are even periods here where the viral load is less than 100 or even undetectable who still go on to develop malignancy later, which I think indicates that that oncogenic process may continue even after the viral load is undetectable. So to summarize those 8 cases, you can see there's a lot of variability in the time to BK positivity for these patients. time between BK positivity and cancer development does range between 3 to 8 years after first detection. What is clearly evident is that in half of these cases, the cancer rapidly underwent metastasis to bowel and peritoneum, and patients died shortly after diagnosis. Of note, these cases do tend to run high immunosuppression levels. In this case, there were 2 second graft kidney pancreas patients, as well as a patient with lung transplant. So given the association with malignancy, we need effective strategies and management for BK viremia and nephropathy. Currently, the standard of care is sequential reduction of immunosuppression and monitoring for concurrent rejection. A meta-analysis of patients on triple immunosuppression showed that for BK viremia, reduction in immunosuppression leads to undetectable levels in 80% of cases, and strategies do vary amongst centres depending on reduction in anti-metabolite versus calcineurin inhibitor or both. There is a consideration of switching mycophenolate to mTOR, as this has been shown to have some antiviral properties previously. There was recently a paper called the BK EVA trial with 130 patients who looked at those with BK viremia and examined the reduced mycophenolate compared to swapping mycophenolate to everolimus. The reduced mycophenolate group did clear BK faster, up to 80% at 6 months compared to 55% in the everolimus group. And rates of rejection between these two were comparable. With regards to zidofovir, there's not been any randomized controlled trials, and leflunomide, some of our patients in this series were trialled on this. There has been some positive case series previously, and there's evidence for in vitro antiviral activity. However, there's not been a randomized controlled trial for this, and a phase 2 trial showed no efficacy as well. IVIG has been used at our centre as well in a number of these cases. One trial of 86 patients with BK nephropathy showed, compared to standard of care and reduction of immunosuppression, there was some efficacy in reducing BK viral load at 6 months. And currently the BEAT BK trial is ongoing. There is also off-the-shelf viral-specific T-cell trials available as well in Australia. The other key take-home messages I wanted to highlight was really that the prolonged positivity and the high viral load for over 12 months seems to really be consistent across these cases. It's clear that the BK in the serum can be falsely reassuring as well when it becomes negative before aggressive cancer. For future thoughts, I think urine cytologies for these patients is quite important.